Good afternoon, everyone. It gives me immense pleasure to welcome all of you today to today's PG Forum class. And today we have with us eminent teacher, my very good friend, Dr. Rohan Palshetkar. He is the head of unit Bloom IVF at DY Patil Institute. He is the second joint secretary of the AMOX, joint treasurer of MAGE, managing committee member of the MSR and MOGS, associate professor at DY Patil School of Medicine, and he has received a number of awards. And to name one of them would be the AOFOG Young Gynecologist Award, which he won in Philippines last year. So he is a great teacher, a great personality, and I would definitely say he is one of those active members who loves working along with teaching. So it's a great pleasure to welcome him to this platform. And I'm very sure, my dear students, that you will definitely benefit a lot from him. And he is going to today talk on screening in pregnancy. So over to you, Rohan. And we have the next couple of hours, so you can take your time, teach them as well as you can, and then they will definitely benefit from it. So over to you, Rohan.
Definitely. Thank you so much, Priyankar. In fact, our AOFOG award, which we got, Priyankar and I, in fact, received it together in 2019 at Philippines, and that was the start of our budding friendship. I think today is Christmas Eve, and I genuinely enjoy the dedication some of the PGs are showing by even logging in on Christmas Eve before a small break tomorrow itself. So today I'm going to be talking about screening in pregnancy. So now this is a very important topic when you look at it exam point of view. The entire thing is that, I'm sorry, just 1 second. I just want to hide this. Yeah. So when I look at it, screening in pregnancy exam point of view is very important. So I'm going to try and go over each point as much as I can, give you the history, a little bit of the in-depth knowledge and some of the recent advancements that have happened in the field as well as on behalf of FOXY as well. I've tried to stick to the studies which have been released mainly by FOXY and ICOG because they're more relevant to our Indian population. So why do screening firstly
Rohan,
for our
just a
mothers?
second. Sorry to interrupt. Students, you can put in
No
your
problem.
questions at the Q&A box, and Rohan will be there to answer it at the end of the session gets over. So you can start putting the questions once you feel you have any doubt. Yeah, thank you, Rohan. Please continue.
Absolutely. Okay, thank you. So as I said, why do we screen? Like all pregnant mothers at some point or the other are going to get divided into high risk and low risk. Now, if you go to see the the age at which the patients are also coming in is at two extremes. Some are in their teens, some are beyond 35. So now when you look at it, how do you divide it into high risk and low risk? Again, those are different equations altogether. So you have to get a good maternal history. You have to look at the age. You have to look at any previous history of any diabetes, hypertension, anemia, pre-pregnancy anemia, and then divide them into high risk and low risk. Secondly, why are you screening? Again, is to prevent any maternal complications from happening. It's important that you diagnose any heart murmurs, any heart diseases in the first trimester. You check for any anemia, you check for hypertension, your diabetes, you check the fetus for any chromosomal errors, for any structural defects, any growth abnormalities. And it's also important when to deliver the patient and how to deliver the patient. Ideally, we all say that all patients should go towards normal delivery, but again, there are certain conditions where there could be some absolute and relative indication. Again, the time, obviously, everyone must be thinking that 37 weeks onwards is generally considered full term. But then again, you may have some hydrops cases which may need to be delivered early, or there could be PPROM. So in such cases, you have to even consider a reason why you need to deliver early as well. Now, these are a couple of algorithms over the next few slides, which I'm going to show you, which came out with FOXY as in 2017-18 in Dr. Vishma Pai's year. So what basically they did was a lot of the experts from all over India came down and did a complete sit down of screening in pregnancy throughout the first trimester, the second trimester, as well as the third trimester. You can see this beautiful algorithm. In fact, it's available easily on the net itself. If you just type in on Google screening in pregnancy FOXY, you'll get this algorithm very easily. And in fact, if you have a question on a screening in pregnancy, putting down this algorithm is going to help you score your marks, and it'll help you to show your examiner that, okay, look, I know the basics, and then you can further on increase your answer by writing more about each of these topics. As I said, the next few slides are just going to tell you the recommended, preferable. Don't worry, I'm going to go over them more in detail as I come to the first, second, and third trimester. Again, in the second trimester, what are the tests which need to be done? What are the markers which need to be carried out? Third trimester, again, you have more screening tests which can be done to divide these patients into high risk as well as low risk. So now let's begin with the first trimester screening. Sorry for this. Yeah. So first thing, what happens is when a patient comes in, you observe that whether the patient is going to fit into your BMI of normal, low, or high. Now, what do we have to consider when the patient walks in? I think all of you are at your hospitals where you're doing your residency, check the weight and blood pressure of the patient immediately. So what do you have to consider? If the BMI is too high, you have to consider these patients as high-risk pregnancies. You have to ensure that they don't gain further weight during their pregnancy, in the sense that you have to obviously increase the weight, but you don't want them putting on 15, 20 kgs. Ideally, they say the weight to be gained is about 6 to 12 kgs throughout the pregnancy. But again, at the same time, you have to ensure that they are able to stick to that. You have to institute lifestyle modification. Just because they're obese and pregnant doesn't mean that they can't exercise. Nobody's asking you to give them a calorie restrictive diet, but what they do require is a good nutritional therapy, which is going to possibly consider them helping them maintain their weight and put on weight in a healthy manner. Then medical therapy, metformin could be used. Daily exercise can be advised to these patients. And you also have to start preparing for a safe delivery, ensuring that they are at a tertiary care center with all possible facilities available to you, because these patients usually can develop possibly hypertension as well as diabetes and in pregnancy as well. Besides that, the patient comes in, common tendency of ours is, okay, patient comes in, okay,
Sorry. Hi, am I audible again?
Yeah, yes, you're audible again.
Yeah, Rohan, go on. Yeah, sorry. Do you all know where I went off?
Yes, sir. Yes, sir.
I think I was here.
Did go off, but you're back now. Please continue.
Yeah,
I think
hi.
it's back now. Rohan, no problem, Rohan. Continue.
Thank you, Ashwat sir. Nice to see you. Thank you for this opportunity.
No problem. What is it? Continue. Now there is no problem. It is clear. Okay.
All right, sir. Thank you. So I think I was talking about your general examination. I'm just going to repeat it. Check for the murmurs. Check the lungs for any rhonchi. Check the breast for any lumps or any nipple discharge which may be there. Check the abdomen for scars or lump surgery if there's any cyst present. First speculum examination, I think this is a must. Consider is check for any discharge, check for the presence of polyps, check for the erosions if there are any on the cervix, check for take this as an opportunity HPV simultaneously, because this can detect any cases during the pregnancy itself. Check the anus for the sentinel pile, because sometimes during pregnancy the patients are going to develop a little bit of piles and they're going to complain of constipation, etc. Then another thing, I think all of you are anyways doing this, checking the hemoglobin, you're checking the, but I think what's important is check for the peripheral smear. If it's hypochromic and microcytic, I think it's very clear that we just consider that iron deficiency anemia. But don't immediately do that. Check the iron studies, do a HB electrophoresis, because even a thalassemia patient can show you a hypochromic and microcytic picture. In fact, I want to give you an example of one patient of ours. The hypochromic microcytic, and we were pretty sure it was possibly a iron deficiency anemia. In fact, we were thinking of just giving IV iron at that point, but then we just said, okay, let's just get her iron studies and hemoglobin HB electrophoresis done. Over there, we found out that she had thalassemia minor. And because of that, her serum ferritin and all her levels were fine. So she required maybe blood transfusion rather than iron at that point. Another thing, if the peripheral smear is normochromic or macrocytic, check your vitamin B12, check your retic count. It could just be vitamin B12 deficiency and folic acid deficiency, and maybe just supplementing with, you need to do is your infection screening. I think it's extremely important that you do for every patient. I think the CBC has been done by every postgraduate at their centers. You end up doing your urine routine microscopy, and I think after you do your urine routine microscopy, if you see pus cells, you think of doing a midstream urine culture. A high vaginal swab should also be considered at that point when you're getting to see these patients. Obviously, I think all you postgraduates are doing your HIV, hepatitis B, HCV, and VDRL. Another thing what you should consider doing is your rubella antibodies to see if these patients have been vaccinated or no. You don't need IgG. If it's high and positive, that means your patient is protected against rubella. Remember, simple mnemonic, GC. So if GC meaning chronic, so your general condition GC, that's how I remember. IgG is for chronic this, and IgM is for something that's acute. Sorry. So another thing that we always check for, what you do is check the blood pressure in both arms. Patients may develop extremely low blood pressure because anyways in a pregnancy, the patient, it's a state of vasodilation. Sorry, I hope you can hear me clearly. You check for blood pressure in both arms, sitting as well as you check for the Korsakoff sounds and accordingly check. In hypotension, as I was saying, in pregnancy, it's a state of vasodilation. So sometimes you may just need to increase their sodium and potassium intake. Then there's also a screening test, what you do for gestational hypertension. Basically, the placental growth factor.
Yes.
People will keep logging in.
Yes. Okay. So good afternoon, everyone. It gives me immense pleasure to welcome all of you today to today's PG Forum class. And today we have with us eminent teacher, my very good friend, Dr. Rohan Palshetkar. He is the head of unit Bloom IVF at D.Y. Patil Institute. He is the second joint secretary of the AMOGS, joint treasurer of MAGE, managing committee member of the MSR and MOGS, associate professor at D.Y. Patil School of Medicine, and he has received a number of awards. And to name one of them would be the AOFOG Young Gynecologist Award, which he won in Philippines last year. So he is a great teacher, a great personality, and I would definitely say he is one of those active members who loves working along with teaching. So it's a great pleasure to welcome him to this platform. And I'm very sure, my dear students, that you will definitely benefit a lot from him. And he is going to today talk on screening in pregnancy. So over to you, Rohan. And we have the next couple of hours, so you can take your time, teach them as well as you can, and then they will definitely benefit from it. So over to you, Rohan.
Definitely. Thank you so much, Priyankar. In fact, our AOFOG award, which we got, Priyankar and I, in fact, received it together in 2019 at Philippines, and that was the start of our budding friendship. I think today is Christmas Eve, and I genuinely enjoy the dedication some of the PGs are showing by even logging in on Christmas Eve before a small break tomorrow itself. So today I'm going to be talking about screening in pregnancy. So now this is a very important topic when you look at it exam point of view. The entire thing is that, I'm sorry, just 1 second. I just want to hide this. Yeah. So when I look at it, screening in pregnancy exam point of view is very important. So I'm going to try and go over each point as much as I can, give you the history, a little bit of the in-depth knowledge and some of the recent advancements that have happened in the field as well as in on behalf of Foxy as well. I've tried to stick to the studies which have been released mainly by Foxy and ICOG because they're more relevant to our Indian population. So why do screening
Rohan,
firstly
just
for our
a
mothers?
second. Sorry to interrupt. Students, you can put
No
in your
problem.
questions at the Q&A box, and Rohan will be there to answer it at the end of the session gets over. So you can start putting the questions once you feel you have any doubt. Yeah, thank you, Rohan. Please continue.
Absolutely. Okay, thank you. So as I said, why do we screen? Like all pregnant mothers at some point or the other are going to get divided into high risk and low risk. Now, if you go to see the the age at which the patients are also coming in is at two extremes. Some are in their teens, some are beyond 35. So now when you look at it, how do you divide it into high risk and low risk? Again, those are different equations altogether. So you have to get a good maternal history. You have to look at the age. You have to look at any previous history of any diabetes, hypertension, anemia, pre-pregnancy anemia, and then divide them into high risk and low risk. Secondly, why are you screening? Again, is to prevent any maternal complications from happening. It's important that you diagnose any heart murmurs, any heart diseases in the first trimester. You check for any anemia, you check for hypertension, your diabetes, you check the fetus for any chromosomal errors, for any structural defects, any growth abnormalities. And it's also important when to deliver the patient and how to deliver the patient. Ideally, we all say that all patients should go towards normal delivery, but again, there are certain conditions where there could be some absolute and relative indication. Again, the time, obviously, everyone must be thinking that 37 weeks onwards is generally considered full term. But then again, you may have some hydrops cases which may need to be delivered early, or there could be PPROM. So in such cases, you have to even consider a reason why you need to deliver early as well. Now, these are a couple of algorithms over the next few slides, which I'm going to show you, which came out with Foxy as in 2017-18 in Dr. Rishma Pai's year. So what basically they did was a lot of the experts from all over India came down and did a complete sit down of screening in pregnancy throughout the first trimester, the second trimester, as well as the third trimester. You can see this beautiful algorithm. In fact, it's available easily on the net itself. If you just type in on Google screening in pregnancy Foxy, you'll get this algorithm very easily. And in fact, if you have a question on screening in pregnancy, putting down this algorithm is going to help you score your marks, and it'll help you to show your examiner that, okay, look, I know the basics, and then you can further on increase your answer by writing more about each of these topics. As I said, the next few slides are just going to tell you the recommended, preferable. Don't worry, I'm going to go over them more in detail as I come to the first, second, and third trimester. Again, in the second trimester, what are the tests which need to be done? What are the markers which need to be carried out? Third trimester, again, you have more screening tests which can be done to divide these patients into high risk as well as low risk. So now let's begin with the first trimester screening. Sorry for this. Yeah. So first thing what happens is when a patient comes in, you observe that whether the patient is going to fit into your BMI of normal, low, or high. Now, what do we have to consider when the patient walks in? I think all of you are at your hospitals where you're doing your residency, check the weight and blood pressure of the patient immediately. So what do you have to consider? If the BMI is too high, you have to consider these patients as high-risk pregnancies. you have to ensure that they don't gain further weight during their pregnancy, in the sense that you have to obviously increase the weight, but you don't want them putting on 15, 20 kgs. Ideally, they say the weight to be gained is about 6 to 12 kgs throughout the pregnancy. But again, at the same time, you have to ensure that they are able to stick to that. You have to institute lifestyle modification. Just because they're obese and pregnant doesn't mean that they can't exercise. Nobody's asking you to give them a calorie restrictive diet, but what they do require is a good nutritional therapy, which is going to possibly consider them helping them maintain their weight and put on weight in a healthy manner. Then medical therapy, metformin could be used. Daily exercise can be advised to these patients, and you also have to start preparing for a safe delivery, ensuring that they are at a tertiary care center with all possible facilities available to you, because these patients usually can develop possibly hypertension as well as diabetes and in pregnancy as well. Besides that, the patient comes in, common tendency of ours is, okay, patient comes in, okay,
Sorry. Hi, am I audible again?
Yeah, yes, you're audible again.
Yeah, Rohan, you are. Go on.
Yeah, sorry. Do you all know where I went off?
Yes, yes, sir.
I think I was here.
Did go off, but you're back now. Please continue.
Yeah,
It
hi.
is back now. Rohan, no problem. Rohan, continue.
Thank you, Ashwat sir. Nice to see you. Thank you for this
No,
opportunity.
oh, no problem. What is it? Continue.
Thank
Now there is no problem. It is clear. Okay.
All right, sir. Thank you. So I think I was talking about your general examination. I'm just going to repeat it. Check for the murmurs, check the lungs for any rhonchi, check the breast for any lumps or any nipple discharge which may be there. Check the abdomen for scars or lump surgery if there's any cyst present. Do a first speculum examination. I think this is a must. Consider is check for any discharge. Check for the presence of polyps. Check for the erosions if there are any on the cervix. Check for take this as an opportunity HPV simultaneously, because this can detect any cases during the pregnancy itself. Check the anus for the sentinel pile, because sometimes during pregnancy the patients are going to develop a little bit of piles and they're going to complain of constipation, etc. Then another thing, I think all of you are anyways doing this, checking the hemoglobin, you're checking the, but I think what's important is check for the peripheral smear. If it's hypochromic and microcytic, I think it's very clear that we just consider that iron deficiency anemia. But don't immediately do that. Check the iron studies. Do a HB electrophoresis, because even a thalassemia patient can show you a hypochromic and microcytic picture. In fact, I want to give you an example of one patient of ours. The hypochromic microcytic, and we were pretty sure it was possibly a iron deficiency anemia. In fact, we were thinking of just giving IV iron at that point, but then we just said, okay, let's just get her iron studies and hemoglobin HB electrophoresis done. Over there, we found out that she had thalassemia minor, And because of that, her serum ferritin and all her levels were fine. So she required maybe blood transfusion rather than iron at that point. Another thing, if the peripheral smear is normochromic or macrocytic, check your vitamin B12, check your retic count. It could just be vitamin B12 deficiency and folic acid deficiency, and maybe just supplementing with, you need to do is your infection screening. I think it's extremely important that you do for every patient. I think the CBC has been done by every postgraduate at their centers. You end up doing your urine routine microscopy, and I think after you do your urine routine microscopy, if you see pus cells, you think of doing a midstream urine culture. A high vaginal swab should also be considered at that point when you're getting to see these patients. Obviously, I think all you postgraduates are doing your HIV, hepatitis B, HCV, and VDRL. Another thing what you should consider doing is your rubella antibodies to see if these patients have been vaccinated or no. You don't need IgG. If it's high and positive, that means your patient is protected against rubella. Remember, simple mnemonic, GC. So if GC meaning chronic, so your general condition GC, that's how I remember. IgG is for chronic this, and IgM is for something that's acute. Sorry. So another thing that we always check for, what you do is check the blood pressure in both arms. Patients may develop extremely low blood pressure because anyways in a pregnancy, the patient, it's a state of vasodilation. Sorry, I hope you can hear me clearly. You check for blood pressure in both arms, sitting as well as you check for the Korsakoff sounds and accordingly check. In hypotension, as I was saying, in pregnancy, it's a state of vasodilation. So sometimes you may just need to increase their sodium and potassium intake. Then there's also a screening test, what you do for gestational hypertension, basically the placental growth factor as well as the uterine artery Doppler flow indices. Now there's something known as the HDP gestosis score. That's hypersensitive disorders of pregnancy gestosis score. It was in fact done by Foxy and ICOG in 2019 itself in Dr. Nandita's year. And in fact, Ashwath Kumar sir was a part of that team, which eventually developed this score with Dr. Suchitra, Dr. Gorak, Dr. Tushar Kar, Dr. Alpesh sir, Dr. Mandani and everyone. In fact, what is this HDP gestosis score? It gives you a primary clinical assessment for the screening as well as prediction of preeclampsia objectively. So there's no subjectivity that it's going to change from person to person. Here, each high risk factor is given a score starting from 1, 2, and 3. If your total score is equal to 3 or more than 3, the patient has to be considered as a high risk for preeclampsia. So these are the risk factors which are present, which I have scored in this manner. If you want to take a picture of this, but the scores are again given on the Foxy website and you can easily get them. So basically, if you look the age older than 34 or younger than 19, maternal anemia, obesity, being a primary gravida itself, a short duration of sperm exposure, that's cohabitation, woman born as small for gestational age, family history of cardiovascular disease, PCOS, interpregnancy interval of more than 7 years, conceived with ICSI or IVF treatment, 1. Again, your mean arterial blood pressure more than 85, pregnancy, all these were given a score of 1. If you look at the other points, your maternal hypothyroidism, if there's a family history of preeclampsia, gestational diabetes, if the patient is obese, multi-fetal pregnancy, hypertensive disorder during the previous pregnancy, all these are given a score of 2. If you look at it, then you already have a high risk, and I think all of you already know it, like your pre-gestational diabetes mellitus, if the patient's chronic hypertensive, any mental disorders, any acquired thrombophilia, any maternal chronic kidney disease, autoimmune disease, or any IVF procedure which involves maybe an oocyte donor or surrogacy treatment. So remember one thing, a self cycle, if you go to see, is just score of 1. But if a donor egg or surrogacy has been done, you automatically give it a score of 3. So if you get a score of 3 or more, you have to take these patients as high risk and treat them as a high risk for preeclampsia throughout. You can consider starting treatment with Ecosprin, say at around 75 or 150 milligrams. Ideally, it's preferred 150 milligrams with all the current studies there are as a precautionary thing from 12 weeks onwards. So how do you do a first trimester screening for preeclampsia? So you need to do an effective screening by measuring the uterine artery pulsatility index from 11 to 13 weeks in combination by taking the maternal history, checking the maternal blood pressure, doing your PAP-A as well as your placental growth factor. That's PLGF, not PIGF. You can also predict over 90% of early onset preeclampsia cases by using a combination of all of these. So how do? You do an effective screening of preeclampsia that can be achieved by measuring the uterine artery PI at 11 to 13 weeks. Your PLGF is basically what is your placental growth factor? It's an angiogenic growth factor that's produced exclusively by the trophoblast. In normal pregnancy, your PLGF should increase. However, when your PLGF levels are low, it's associated in cases with preeclampsia. So it gives you a 90% chance that if your PLGF is low, then your patient is at a high risk of preeclampsia. So what's the aim of now? Another thing is a dating scan. Obviously, which you're going to do is confirm the viability, establish gestational age, check the number of fetuses if there's a presence of twins, check for amniosity if there are twins, and chorionicity as well. Now, the International Society of Ultrasound in OBGY suggests that the first scan should be done between 11 to 13.6 weeks. I'm sure a lot of your eyebrows have just raised up right now. Yes, it says 11 to 13.6 weeks, but I think in our population, in a practice where we are doing regular, patients come in early, I think it's important to allay their anxiety, and where we do have private clinics, we do have even government setups which do help us do these scans early, really ends up allaying the anxiety of couples who have just conceived or maybe have even taken time to conceive. So I generally personally do my own scans between 6 to 8 weeks, but the International Society does say between 11 to 13.6 weeks, but it can be done anytime in between that. I think earlier the scan is better for your deciding your estimated date of delivery, and I think that helps a lot. So how do you do your dating? So you generally check the crown rump length to assess your gestational age. When you look at the cardiac activity has been documented as early as 37 days. That's 6 weeks itself. Cardiac activity is usually seen when the embryo measures around 2 millimeters, but in about 5 to 10% of viable pregnancies, the cardiac activity may not be seen in embryos between 2 to 4 mm. Sometimes you may see that the radiologist writes, kindly send the patient follow up after 2 weeks for cardiac activity. So that's probably those 5 to 10% of cases where the cardiac activity may not be seen, and a repeat scan may need to be done after 1 to 2 weeks to assess the cardiac activity. Now, NT scan. Now, this is the part where your screening really holds a lot of importance, because this is going to tell us about how the fetus is doing. Is there any chromosomal abnormality in your fetus? Mainly what we are testing is for Down syndrome, Edwards, and Patau's. All right. So when you look at nuchal translucency, it's behind the fetal neck in the first trimester. So as your NT increases, the risk for aneuploidy also increases. Now you're going to wonder what exactly is the nuchal thickness. So generally a cutoff of 2.5 mm is considered, where above 2.5 mm, you're more worried about the baby having a chromosomal abnormality. Generally, sensitivity of this test along with maternal age gives us almost a 90% idea about whether this baby is going to have a chromosomal abnormality. The NT scan is usually done between 11 to 13 weeks when a corresponding crown rump length of 45 to 84 mm is seen. So now, along with nuchal translucency, you can also do a nasal bone. This improves the performance of the combined screening from basically from your 90% to 93%, and it decreases the false positive rate from 5% to 2.5%. Besides this, what you do is add biochemical markers such as your free beta HCG, not your regular one, but free beta HCG, and your pregnancy associated plasma protein A, which we all know as PAP-A. Please, during your exams, at least write the full form in one at some point of your answer. And even when speaking during your vivas, don't say PAP-A. Say the full forms. It's always more preferable for the examiners. As you can see, generally beta HCG, your free beta HCG is much higher in Down syndrome, and while in Edwards and Patau it's low, while your PAP-A is low throughout in all three of the tests, all three of the chromosomal abnormalities. So when you combine all of these, the NT scan, the nasal bone, as well as the biochemical markers, you get a much better sensitivity as well as specificity. So what's the major advantage of this combined test? It's non-invasive. The result is provided early. It helps in decision making, that in case there is Downs, Edwards or Patau's, once it's or we need to confirm that it's Downs, Edwards or Patau's, we can consider doing that. Down syndrome, maybe if it's clear cut, then maybe an early termination would be possible. And the sensitivity is very high without really having any invasive procedures. Now, another thing what you can do at the same time with the NT scan is check the cervical length. It says that it's done between 16 to 20 weeks, but I think we are doing them much earlier now because the sensitivity of the scan machines, and I think the technical know-how of all the gynecologists and radiologists has become a lot better. But as per the American College of OBGY, prior to 16 weeks, it makes it difficult to distinguish between the endocervical canal and the lower uterine segment. And routine cervical length measurement after 24 weeks of gestation is not really done because most of the interventions are used, basically a cervical encirclage or anything like that is done generally prior to 24 weeks. Now, cell-free DNA. This basically is present in the maternal blood from early pregnancy and is washed out in soon after delivery. It generally emanates from the placenta and contains the entire fetal genotype. So if fetus has Down syndrome, there will be more chromosome 21. Now, when I talk about NIPT is non-invasive pre-heart, and you see that there is chamber asymmetry, like your chambers are not in symmetrical in size to each other. If there's an altered cardiac axis, if there's an altered position of fetal heart, if the fetal heart is enlarged, or if you track any arrhythmias during the scan itself. So ideally, the fetal echocardiograph is performed between 18 to 22 weeks of gestation. After 30 weeks, the shadowing effect of the ribs and the ratio of fetal body mass to amniotic fluid increases. So you don't get a very clear-cut picture, and you're not able to pick up the minor diseases which may be missed out. Yeah. So early maternal transabdominal or transvaginal scan at 11 to 14 weeks in a patient with nuchal translucency, you must consider doing a fetal 2D echo. And the first trimester, usually the cardiac details can't be elicited very well. But if you look at a pulsatile ductus venosus or you see a tricuspid regurg, they can be very strong markers for cardiac and chromosomal abnormalities. So maybe in the anomaly scan, you may want to look for it if everything has been ruled out by either CVS or amniocentesis. At your anomaly scan, you still should consider doing a fetal 2D echo at that point. What are the pitfalls of this fetal 2D echo? Sometimes lesions such as minor VSDs could be missed. Progressive defects such as bicuspid aortic valve may not be diagnosed at 18 to 20 weeks. They may be diagnosed at, say, 24 weeks. In fact, in India, I think most of the fetal 2D echoes are done at around 24 weeks. Outflow tract anomalies could be missed. Maternal habitus and fetal life. It's not in the right position. The fetal 2D echo may not be done. Visualization of the detailed heart would possibly not be visible before 18 weeks of gestation. Fetal 2D echo, again, it may be difficult or time consuming to perform a dedicated fetal echocardiogram on all patients. So it's very important that you triage the patients that have to go in for fetal 2D echo. a 4-chamber view, the outflow tracts, the 3-vessel view could be sufficient to diagnose over 80 to 85% of cardiac anomalies. Screening for GDM. Now, you have to understand that gestational diabetes mellitus is very common in our country. In fact, it's said that Indian women have 11 times more risk factor of developing GDM as to their Western counterparts. Now, there have been multiple screening tests in different countries using the American Diabetes Association, Performa, the WHO, etc. Now, what is the reason for screening GDM? Now, understand insulin is detectable in fetal pancreas as early as 9 weeks. And there is an increase in pancreatic beta cell mass and insulin secretion by 16 weeks. Now, what happens is if your mother is diabetic, your beta cell mass, your insulin, hyperinsulinemia starts occurring, which causes fat deposition and increases the baby size. So therefore, it's very important that you catch these GDM patients so they can be treated well and the other complications of GDM can be managed. The usual recommendation for screening of GDM is between 24 to 28 weeks. Now, this is where I want to say that, yes, ideally it's said between 24 to 28 weeks, but it's preferred that you do it in all 3 trimesters. Do it in your first trimester, repeat it in the second trimester, and then in the third trimester, we shall do it again to just see how the how the patient is tolerating the glucose. Now, let's look at the American Diabetes Association. They consider 2-step process, one for screening and one for diagnosis. Step 1, you give a 50-gram glucose challenge test. If even one of the values, so they do it at say about 0 and 2 hours. If one of the values is more than 140, then they do a 100-gram glucose challenge test where blood is collected at 0, 1, 2, and 3 hours. The drawback is multiple number of blood samples are required. 2 visits to the hospital are required, one for screening and one for diagnosis. In a country like ours, where patient follow-up is sometimes very difficult, especially in the lower socioeconomic strata, which most of the patients are going to the government centers, waiting in line for that long to just get the test and all thing done. We need something that's more simple and straightforward, which is going to straight away give us an answer. So that's when the DIPSI test came into place. So what you do is give 75 grams of glucose in water to a patient, irrespective of their fasting state. And you just collect 1 sample after 2 hours. The advantage is that the pregnant woman doesn't need to be fasting. There's no disturbance in the regular schedule, and it serves both as a screening as well as diagnostic test. So if you can see that a glucose value of more than 200 in pregnancy and outside pregnancy would both be diabetes. Between 140 to 199 is when if the patient was not pregnant, we would have said impaired glucose tolerance, but here we consider as gestational diabetes. Between 120 and 140 is considered as gestational glucose intolerance, and below 120 is considered normal. So screening for PIH, basically what you do is now every trimester, I know I haven't gotten to this a little earlier, but I wanted to go as much as possible through the scans and the markers first. So for PIH in your second trimester, what do you do? Check the blood pressure, monitor the blood pressure again at every ANC visit of the patient. Check for the weight gain. Has she, as your textbooks say, has she gained more than 5 kgs in a month? Has she gained more than 1 kg in that week if she's come after 1 week? Do a urine albumin. You get your dipstick test, which I think all the postgraduates are using in their day-to-day practice at their hospitals. So that helps. Remember, LDH is raised in HELP syndrome. So if you're doing your entire pH profile of your LFTs, RFTs, your PTNR, RBS, etc., make sure that you get this done. In all your visits, remember, check your weight, blood pressure, and the uterine size. Physical examination is a must in every trimester and at every ANC visit. I know that during this COVID time, it's a different situation, but remember that you need to check, because just a clinical examination of the uterus can sometimes give you a lot of answers. Check for pedal edema, other signs of PIH, such as epigastric pain, nausea, vomiting. Now, do not overlook epigastric pain as acidity. Why have I written that as in bold, in capital? Very commonly, patients come with indigestion and we just take it extremely lightly. I'm actually going to tell you an incident that happened to me during my residency days close to almost 10, 12 years ago. At our hospital, patient's blood pressure used to be taken by the interns, and then the patient would come in. So the patient came in, we saw the patient started complaining of epigastric pain. So I just, by chance, just looked at the foot of the patient, and there was massive pedal edema. So I decided to take the blood pressure myself. She also said that I've been having epigastric pain, and as a thing that, okay, she's pregnant, she's just going to have this indigestion. So I said, oh, okay, all right, is this happened after you've eaten food? Has this increased? She said, no, this has happened since I woke up. So that actually raised the alarm bells. When I checked her blood pressure was 160 by 110. Eventually that patient went into HELP syndrome. She delivered, everything luckily went well, but it was important for us to catch her that early before she went into that HELP. We caught her just in time before all the parameters started worsening. We induced her, delivered her normally. There was a little bit of tears and everything, but she never went into DIC. And I think that catching that patient early made the difference. Vaccination, again, not a part of screening, but I think it's important that the tetanus toxoid vaccine should be given 1 dose, and then now your Tdap vaccine, which is basically your tetanus, diphtheria, and pertussis vaccine after 24 weeks. If your Tdap vaccine is not available, just do another 2nd dose of tetanus after 4 to 6 weeks. It's fine. Influenza vaccine 24 weeks onwards. The targeted vaccines in case of travel to endemic areas. Postpartum HPV vaccine can be considered. Considering now the COVID vaccine, which has come into play recently, the American College of OBGY as well as the American Society of Reproduction is saying that it is safe to give it to pregnant patients as well as breastfeeding. However, the RCOG simultaneously is currently saying that it's not yet safe to give in pregnancy and this breastfeeding mothers. So I think the answer still awaited. We can't really make a decision regarding whether to vaccinate during pregnancy or no. So that's one dilemma, I think, which will probably get sorted out in a few months or so. But till then, I think we just need to keep following with whatever the latest news that comes from FOXC, ICOG, RCOG, ASRM, etc. So a quick recap of the 2nd trimester that we've gone through. Again, check the BMI preferably, check the mean arterial pressure, your CBC, electrophoresis may not be required now because I think you've already done it in your 1st trimester, but if you've not, repeat it. Do a quadruple marker, NIPT is preferred though. Anomaly scan, instead of just a regular 2D anomaly scan, do a 3D, 4D scan along with a 2D echo. Check the cervical length. As I said, it's ideally, as per the guidelines, 16 to 20 weeks. The DIPSI test is recommended, preferable to your OGTT of 0, 1, and 2, and 3 hours as well if you want. But I think the HbA1c and a DIPSI test is more than enough. So now let's get to the final trimester, 3rd trimester screening. I think this more than screening, it ends up becoming a little bit of surveillance along with your screening methods. So when your 3rd trimester screening, again, you're repeating your CBC, you're repeating your thyroid, DIPSI, urine testing. You're going to do a physical examination, examine the uterus. You're going to check the blood pressure. You're going to do the growth scan and the Doppler and the fetal movement. Now, when I talk of the fetal movement, this is a good way of screening whether the baby is doing well or no. You generally do a daily fetal kick count, which we generally practice is 6 in about 1 hour post-meal, or at least in 2 hours post-meal. If it's less than 6 movements, keep a track. If the movements are on a decreasing trend, I think it's important that the patient comes to your healthcare professional and gets checked out. Now, a Cardiff count. I know we don't use it in our country, but I think it's important at least you know about it for your exam point of view. The Cardiff kick count is basically what we do is we give, the patient starts counting from a certain period of the day every day until she feels 10 movements. Usually 10 movements should be felt in 12 hours. If this goes beyond 14 to 16 hours, it's recommended that the patient come in immediately. This daily fetal kick count, the screening, I think should be considered in all high-risk pregnancies as per your triaging in the first trimester itself. And it should be considered anytime after, say, 24 to 26 weeks, where you need to check the fetal monitoring at home itself. I think the NSTs, again, are a very good thing for fetal surveillance. You could consider them as a screening for fetal viability as well. But generally, they're performed after 30 weeks of gestation. From 24 to 28 weeks of gestation, 50% may come non-reactive. And 28 to 32 weeks, 15% may come non-reactive. Remember, when I talk about the 50% and 15% of normal babies who have no problems at all, they may still come non-reactive between 24 to 28 weeks and 28 to 32 weeks. Remember, do your NST for a minimum of 20 minutes. I know it's a normal tendency of every resident. FHS is there, one acceleration has come, okay, we're done, NST is good. Please do your NSTs for 20 minutes. Sometimes if your NST is non-reactive for 20 minutes, you may have to continue your NST for 40 minutes as well. Look for ominous signs of NST, a lack of beat-to-beat variability. You may just be getting a flat line of less than a beat-to-beat variability of less than 2 to 5 beats. Consider that an ominous sign. Don't think that it's just non-reactive. It's okay. Let's give left lateral oxygen and things like that. Just be aware that, of course, you need to do all that, but don't take it lightly thinking the baby is not moving or anything like that. Variable decelerations due to cord recompression is another sign which you need to be aware of, and late decelerations due to fetal hypoxia. Now, this is the last part which we're going to be covering is Doppler. Now, when we're doing a Doppler, what are the vessels we're looking at? We're looking at the uterine artery, the umbilical artery, the middle cerebral artery, the ductus venosus, umbilical vein, and the fetal inferior vena cava. But generally, when it's reported, I think it's the umbilical artery, the uterine artery, the middle cerebral, and the ductus venosus, which are told. Now, when I look at the uterine artery, see, this is what you will actually see during your scan. And that's where you're actually sampling the process. Now, if you see a persistent bilateral diastolic notch after 24 weeks of gestation, please remember that this is indicative of preeclampsia. The patient may have abruption, check the blood pressure, or existing or impending IUGR. Now, at this point, we have to start screening the patient for IUGR. Look at the symmetry of the growth, look at the weight of the baby, compare the weight of the baby to the previous scan, see if the growth is adequate for the weeks of gestation from the previous. So if you've done a scan at 20 weeks or say at 24 weeks and you repeat at 28 weeks, it's important to see that there's at least been a proper growth. You obviously nowadays the reports with the newer machines, they give you a comparison, let you know the percentile, and that becomes much easier in diagnosing IUGR as well. Also, your clinical examination at this point is going to help a lot. Obviously, any patients which you've already considered as a high risk, you can treat with aspirin, say about 150 mg. This is ideally started at 12 weeks gestation or even earlier. Now, what's the indication of the uterine artery Doppler? If the patient has had a previous or present history of preeclampsia, meaning in the previous pregnancy or currently has preeclampsia but the blood pressure is under control, maternal diseases, a previous child with IUGR, unexplained alpha fetoprotein levels, very high beta HCG levels, very high level of fetal care may be required in high-risk pregnancies. In high-risk pregnancies is the only time you use the uterine artery. You need not do it regularly at earlier gestation. Obviously, at 32 and 36 weeks, I think most of us have now included it as a part of a regular routine ANC care. The test is considered positive if there's bilateral persistent aortic notching. The screen has a high negative predictive value. That is, if the PI of both uterine arteries is normal, the patient is unlikely to develop preeclampsia or IUGR. Understand, negative predictive value. Then we do the umbilical artery Doppler. It's rather than the fetal Doppler. It basically provides the information on the fetal side of the placenta. Flow velocimetry performed at this level represents a downstream resistance, namely at the placental stem and terminal villi. Now, if I go to see what are the factors that could affect the umbilical artery flow, your end diastolic flow velocity increases with gestational age. It decreases with the decreasing fetal heart rate. It increases with the variability in measurements. Your end diastolic flow velocity is going to be higher near the umbilical cord insertion in the fetal abdomen rather than the placental insertion. Continuous Doppler is more of a blind technique as compared with the pulse duplex Doppler, allowing more real-time ultrasound. Reliability increases with the increasing experience. So obviously get it done by an experienced radiologist, or if you are trained well in it, definitely do it. Increasing vascular impedance is going to increase your end diastolic flow velocity. Vascular resistance decreases the flow velocity. And if you see the angle, that's again out of the scope of this talk. So generally, you're going to have a sawtooth type appearance. Your S by D of this umbilical systolic by diastolic ratio decreases from 4 to 2 from this at around pregnancy. Your S by D is generally less than 3 at 30 weeks. So if your S by D ratio increases more than 3, then you can understand that the S by D, this is increasing. This can be used as a useful adjunct in the management of pregnancies complicated by fetal growth restriction. It has no risk of, no role in the risk of low risk pregnancies for complications other than growth restriction. Now, what's the predictive value? Now, if your impedance is increased in the umbilical artery, that's more than 60%, that is more than 60% of the placental vascular bed is obliterated. Your absent end diastolic flow and reversal of the end diastolic flow have an associated 40% and 70% perinatal mortality respectively. So now if you have a reversal, consider delivering immediately. Absent end diastolic flow, in fact, the absent end diastolic flow and an MCA PI of less than the 5th percentile are signs of termination of pregnancy immediately. So as you can see in these scans, you can see that the abnormal, this is when you have a high PI in the umbilical artery. Again, you can see that there's an extremely high pulsatility index now in the second, I'm not sure whether you all will be able to see my mouse, but it's all right. In the third photo that you see that there is an absent diastolic flow. There is, if you see, they're just mountain peaks by themselves, which are not joining each other. That shows the absent diastolic flow. And in the last one where the blue image is seen, you can see that there is a reversal of end diastolic flow. So as said, if the S by D ratio in extreme cases of growth restriction and end diastolic flow may become absent or reversed, these are ominous signs. And if there's a reversible reverse end diastolic flow is there, just deliver the patient. The middle cerebral artery is the most studied cerebral artery because one, it's one of the easiest to sample. It provides information on the cerebral blood flow. Remember, the middle cerebral artery is a high resistance flow. So basically what it helps us assess is the fetal cardiovascular distress, fetal anemia, and fetal hypoxia. So if your S by D ratio, your fetal MCA S by D ratio should always be higher than the umbilical artery S by D ratio. So if your fetal, this fetal S by D ratio drops, that means there is something known as a brain sparing effect. Oh, wow, sorry. So brain sparing effect. So that is something, again, that what we need to see. But just because if there is a brain sparing effect doesn't mean you need to deliver. It just means that you need to monitor this patient a little more closely. Measurement of the fetal MCA is a predictor of severe fetal anemia, and it can be avoided it can be used to avoid unnecessary invasive procedures in RH isoimmunized pregnancies. Now, ductus venosus is basically the most accurate interpretation of the fetal cardiac function as well as the myocardial hemodynamics. Now, usually it's useful in assessing severity of hypoxia in IUGR and myocardial compromise. So now if you go to see the triphasic waveform, as you can see, it compares of the S wave, which is basically it corresponds to the systolic ventricular systolic contractions. The D wave is basically to the early ventricular diastole, and it's the second highest peak, as you can see. And the A wave, as you can see, is the trough, and basically it is corresponding to the atrial contraction. When you have an absent or reversal of that A wave, it's an ominous finding under ductus venosus, and it's showing basic complete fetal compromise, and a delivery needs to be done immediately. So typically what's going to happen when you see your Doppler studies, when you see the progressive placental dysfunction, first your umbilical artery S by D ratio increases. You'll get your usual scan saying S by D of umbilical artery is raised. Then you see a decreased cerebral artery PI which says brain sparing effect. Even now you don't need to intervene, you just need to monitor carefully. Absent end diastolic flow in umbilical artery, this is an ominous sign, and it basically says that now I think it's time to terminate the pregnancy. A reversal of end diastolic flow means you must have to deliver now, otherwise there's a chance of IUFD. Therefore, and then there's an increase in the PI of the ductus venosus and reversal of the A wave in the ductus venosus. Now, I just want to discuss one case with all of you. I had a patient, IVF conception, 43-year-old, had never conceived before. She had a absent and diastolic blood flow at 23 weeks. Now, obviously, this is a very offhand case. This is something that I think rarely something we would do. The patient was obviously affording, so she was well read as well. So we said that, look, you've got absent and diastolic flow at 22 weeks. Very unlikely that we're going to be able to continue the pregnancy for longer. We may have to deliver you now. So she said, doc, what are the chances of us getting at least another 2 weeks or 3 weeks? So I said, look, there's always the risk of an IUFD possibility when there is an absent and diastolic blood flow. So she said, okay, doc, what if we do a scan every day to see? So I said, it's completely unheard of. It's completely something that we generally would never do. We actually, then she said, I don't mind. She got admitted and she said, I'll do a Doppler every day. She did a Doppler. We got 3 extra weeks. It was a lucky case. She went up to 25 weeks. We had then a reversal set in. So we delivered. The baby was shifted to an NICU with a 420-gram baby, which was born. The baby was in the NICU for almost 3 to 4 months. And she was lucky that the baby survived and the baby was doing very well at that point of time. So it was just one case which was offhand, which I thought you all should know about, an interesting case that happened with me. Doesn't mean that you do it in every case. Okay. I think it's very important that you look at all the conditions, and this, even if you would have done a scan maybe every 3rd day or every week, once a week, I think that would have been more than enough, provided you've explained to the patient what are the possibilities of the fetus dying in utero. So now a recap and possibly the first final couple of slides of my lecture. You again in your 3rd trimester, check your BMI, mean arterial blood pressure, do a growth scan with Leica volume and placental localization. I think it's very important you add a Doppler velocimetry to your scans, especially after 30 weeks. At least 1 to 2 scans, including your Doppler, would be helpful. Fetal kick count is something which they can do, or NST is always preferable. DIPSY test, or again, I'm not going to get into that. So to conclude my talk, screening in pregnancy is extremely important. Triage your patients into high risk or low risk cases. Help us screen for, this screening helps us screen for any fetal abnormalities. It also keeps the healthcare workers alert towards maternal conditions such as anemia, GDM, PIH, IUGR, fetal malpresentations. And the main aim of our screening is to reduce the maternal and fetal morbidity and mortality. Thank you so much.
Thank you, Rohan. That was a wonderful talk, I must say. You've covered all the aspects of screening very well. And basically, I can totally understand 1 hour of continuous talking. And that was definitely good take-home messages that you have given of the 1st trimester, 2nd trimester, and the 3rd trimester per se. So, Rohan, I see a couple of questions over here. One is from Dr. Afreen Naz, and she asks, American Diabetic Association recommends IADPSG based on the HAPO study, and 2 steps only recommended by ICOG only, is the question. I mean,
I think I'm a little tied up by the short forms used. I'm actually
Yeah.
not very sure about IDPSG. I'm not very sure about that. Maybe Afreen, if you're still logged in, could you just type in the full form of these so I can answer? Otherwise, let me just check and then answer, get back to you later on. But see, at the end of the day, when you're looking at it, you're looking at the Indian population. Uh, you're saying the 2 steps only recommended by ACOG. I don't know about the ACOG, but the American Diabetes Association says that. What my entire aim was that we have to target the Indian population, and I think for the Indian population where we have so many more patients coming to us, and in fact at that point, I think the DIPSI is an ideal procedure, especially which is one-step procedure, gives you the result immediately, not only for screening, but also to decide your treatment protocol for that patient. So I think the DIPSI test is more than enough. And even for your question and answers in your papers, I think if you write just DIPSI, I think it's more than adequate.
Perfectly said, Rohan. I think yeah, that's the perfect answer. And actually, in today's day, for in a question answer or in a viva, you should mention DIPSI, because DIPSI is one that is of the Indian this thing, and Indian basically standard which the DIPSI thing has been made, and it is the ideal test for the Indian population, and you have to mention DIPSI for it, because that is what we look at. The examiners look at that, whether you have mentioned that or not. There's another question from Saras Jyoti Munaswamy, and the question is, what about screening about preterm births?
So, okay, yeah. So preterm birth is basically, obviously there's so many things that have been coming up, but there's no per se, what can you say, a single test. I think the cervical length, as well as you have been having talks about your fetal fibronectin as well, combining both of them and really telling them. But I think currently the cervical length is the most, what do you say, most prominent test which is going to screen for really your preterm birth. Your fetal fibronectin, I think it's currently there is some debate regarding what is its efficacy being used, but I think a regular screening with the cervical length is more than adequate enough to check for screening for preterm. Yeah.
Yeah, thanks, thanks, Rohan.
Any thoughts about that for you?
Yes, so basically the preterm births, yeah, perfectly said. As you have mentioned, Rohan, I mean, of course, the screening has to be done. And as you said, again, preterm births, we would also add on over here, I guess, about the cervical, the recurrent pregnancy losses, which we see in cases of, like, repeated abortions at maybe 20 weeks, at 16 weeks, 18 weeks, 20 weeks, and of course, the cervical incompetence factor comes into a play. You have perfectly said the cervical screening needs to be done, the cervical length screening needs to be done and needs to be looked at. But then we need to mention one thing over here, I guess, that, when we have a cervical incompetence or a short cervical length, nowadays the recommendation says 2 centimeters is when we should start progesterones, and less than 1.5 centimeters, we should go for a cervical stitch. But practically, we know that we don't do it, because that is like really too short for our comfort, and we are still happy with the 2.5 and 3 centimeters that we start.
I think even theoretically, I think that concept needs to change. It even in the textbooks. I think even to all the students, I would want to say that please write 2.5 as a cutoff, even if your textbooks are saying 1 or 2, because your examiners are clinical practitioners. Please understand that. They are doing regular practice. They are not opening a textbook while correcting your papers. They are correcting your papers. They are taking your vivas based on their practical experience as well as guidelines. So I think you still stick to the 2.5 cutoff rather than the 2 for progesterone and 1 for encirclage.
Yes, perfectly said, Rohan. There's a question from the same Saras Jyoti Munaswamy, and she asks you about APLA screening and prophylaxis.
APLA screening, I think APLA screening needs to be very, it's in high risk pregnancy. I think, that's actually a very good thing. I think I missed that out in my talk. So really apologize to all the PGs for that. But I think patients with recurrent pregnancy loss or any history of thrombotic disease in the family or anything, APLA screening needs to be done. And if the APLA test comes positive, then you can start with prophylactic low molecular weight heparin in these patients, starting as early as even 6 weeks. Being Priyankur and I being infertility specialists, we started at the time of a transfer itself. But ideally, it should be started at as early as possible, as soon as the heartbeat starts. And I think a dose of around 40 milligrams is started as a prophylactic dose, and it has to be continued till 1 day prior to delivery. In fact, that's the protocol which is followed by not only us gynecologists, but even if you take a guidance of a hematologist nearby, they would suggest the same thing.
Yes. So perfectly said. And again, I would like to add on one thing in a high-risk pregnancies, which we do. I'm sure Rohan also does the same thing. Is starting off with aspirin, because as folic acid and aspirin, we start off right at the beginning because that definitely helps us. In APLA, of course, we add on low molecular weight heparin, but in bad obstetric history or high-risk pregnancies, aspirin does good to the patient. Now, again, there is a controversy that you would see. People will talk about 75 milligram and 150 milligram of aspirin, but then either it's a two-school thought. 75 if you write in the exam or you say in the viva is good enough. If you say 150, that's also good enough. Both are accepted, but then you need to mention it. So that is very important.
Back up your answers. See, there is no right or wrong, especially in a situation like this, as Priyankur said. Just back it up by saying that there are studies which are debating both on 75 as well as 150. In fact, there are studies which are saying 81 milligrams, but it's not available in India, 81 milligrams. We only have the 75 and 150. So I think it's absolutely fine. Yeah.
Yeah. Thanks, Rohan. Then Afreen has come. She has the IA DPSG, the full form she has put as International Association of Diabetes and Pregnancy Study Group. So Afreen, I think if we go by your question, the ADA recommends IA DPSG. That is very true. But the ADA recommends it as per the American population. It's for them.
Exactly.
We theoretically can mention this when you say there are a lot of guidelines. There is this Kushner guidelines. There are a lot of guidelines that are put out by the ADA. There are a lot of guidelines put out by the European Society. But then please to remember, for the Indian thing, the best is DIPSI, as Rohan has mentioned. We need to talk about the DIPSI guidelines, and that's the best suited for the Indian population. And just remember one thing: guidelines for Indian guidelines are very rare. When you have a guidelines for Indian population, like Rohan mentioned about the Gestrosis score as well as the DIPSI guidelines, please to use it because they are the best suited for the Indian population. I think you'll agree with this, Rohan,
Also,
right?
absolutely. Also understand another thing, that when I'm talking about the Indian guidelines, it's for DIPSI especially. We're talking about a universal screening in India. Here, there's no selective screening in high-risk patients in India. In India, because of the risk of being 11 times more for Indian women, we screen every Indian woman for gestational diabetes mellitus. So in fact, if the Indian guidelines are set in, use those, because again, as I said, there are only 2 or 3 guidelines for Indian populations which are set in for our OBGY field. Stick to them. Do not mention ADA. Do not mention. The reason why I mentioned the ADA was to show why our screening method is superior and more advantageous than theirs. So that is the main reason why I showed it in my study. It was not to confuse you. It was just to prove that our DIPSI test is good and is equally effective.
Perfect. Rohan, there's a request from a couple of students, and they want to know about the algorithm of low, intermediate, and high risk screening that you had shown. So, if it's possible, you could maybe share the screen once.
And I'm looking at the. So again, I'm going to repeat it. When I look at the combined. Yeah.
Yes, I'll go on with the questions in the meantime. You can just look at it.
Yeah.
Okay. Then there's one Dr. Ganesh Bhatta, and he asks, starting of ecospirin, when exactly to start, and any difference for APLA cases for RPL and high risk cases for preeclampsia. Basically, I think he wants to know ecospirin when to start and whether there's a difference in the dosage or when to start for APLA as well as for high risk cases for preeclampsia.
I think APLA cases, you start them as soon as you know that the patient's pregnant. I think that's currently what we're following. I think, again, there's a massive debate on when it would start. In fact, I still remember, if any of you had attended Murlidhar Pai sir's lecture on recurrent pregnancy loss during this PG forum itself. He himself said that 50% this in APLA cases, you need to start as early as possible. But now it depends when the patient comes to you. So because now I'm going to talk about my practice. In my practice, being an IVF consultant, where we end up doing embryo transfers, we start the EcoSprin already at the day of the transfer. So we are starting at, say, we consider the date of embryo transfer as 2 weeks. So we are starting on literally 2 weeks point, we're starting EcoSprin. Patients which conceive naturally and come to you, basically as soon as they come, I think you need to start off the EcoSprin as soon as possible. Now, high risk case for preeclampsia, ideally all the studies which have said that the treatment of EcoSprin of 150 milligrams or 75 milligrams needs to be started at 12 weeks of gestation. But again, they say if you have the opportunity to start it slightly earlier, there is no harm, and you can begin even as early as 8 to 10 weeks as well. The earlier you start, the more chances of you being able to possibly delay the onset of preeclampsia. I don't think your EcoSprin prevents it completely, but I think it delays the onset more than anything else. Priyanka, do you mind if I just quickly go over this one slide so that
No, please do.
Yeah. So when I talk about the when I talk about the NT scan and dual mark, I hope this is the screen what people were asking for. When I say NT scan, I mean your nuchal translucency, your nasal bone, and doing your PAPE as well as your free beta HCG. Now, usually when all these are combined, the lab gives you a risk factor of this. So now that the cutoff says 1:250 is considered as high risk, and intermediate risk depends on each lab to lab, but generally we consider it, say, from 1:250 to 1:500 is what I look at, and low risk would be less than that. Now, if it's a high risk, do your chorionic villus sampling. Intermediate risk, do an NIPT. Remember, your NIPT costs somewhere around 20,000 rupees. So maybe not all patients will be able to afford it. If it's high risk, you'll have to go for CVS. If it's low risk, do a routine ANC follow-up. And if it's a low risk, obviously, just stop the, you don't need to do anything, continue the treatment. Yeah.
Yes, perfect, Rohan. The EcoSprin bit, I'd just like to add on one more thing. Like with the preeclampsia, definitely EcoSprin is helpful. But for the student who had asked, please do remember that calcium is of extreme help. There are a lot of studies which have come up for calcium with preeclampsia, and we can definitely use them.
High dose
and
calcium.
High dose, 1 gram. Yeah, 1 to 2 grams of calcium is what is recommended. And once we're talking about the APLA, as Rohan has said, same, the EcoSprin has to be started as early as possible. Previously, there was a concept of starting it after the cardiac activity was detected, but now that concept has gone and it's as early to be started because it helps. In preeclampsia cases, again, see any high-risk pregnancy, it's best to start EcoSprin at the earliest because the second wave of invasion happens around 14 to 16 weeks. So before you need to catch it before that happens, because the thing is the chances of developing any arterial or any vascular thrombotic disorders will be much lesser. Okay, next question now, Rohan. Just a second. Screen is start. Yeah. So EcoSprin is done. Yes. So cutoff for nuchal translucency, has it changed from 3 mm to 2.5 mm?
Yes, now even the current studies as well as the International Society of Ultrasound and OBGY has used 2.5 as a cutoff. They're saying 2.5 to 3 mm is all right. But beyond 2.5 mm, they said that you have to be more than this. It's more risky for it to be a, what do you say, more chances of it being a chromosomal abnormality than not.
Yeah. Okay. Then we have a question by Anita, and she asks, sir, according to WHO, minimum ANC visits for booked patients is 8 visits. In the Indian setting, do we take Anganwadi center included in it? What is booked patient according to you?
This is a very difficult question, but if I go to look at it practically, I think provided the ANC care is being given properly, all the recommended tests and everything are done, and the ANC care is followed by the Anganwadi team, then I think it's fine. And now midwifery concept may be changing, and these booking visits may need to get counted as well. But personally, currently, while this is not yet fully established, I think it's important that the doctor seeing the patient should be counted as a visit, provided ANC care is there. I think according to WHO, they say 8 visits, but I think the recommended is at least a minimum of 5 visits. More visits, the better it is, and the screening would be better. But a minimum of 5 visits, I think, is ideal.
Perfect. Yeah. So in Indian population, you will see sometimes patients who do not have a single visit come to you in the last minute with a lot of complications. So,
Absolutely.
so for us, as Rohan said, 5 visits or at least 3 visits should be there for one visit per trimester is the minimum, gross minimum for you to have. And then ideally in Indian population, see, you can't see so many women, right? You're talking about the low socioeconomic strata who mainly go to the government colleges, and it's not possible for you to see so many women. So you yourself, when you give your dates, you give it after maybe 6 weeks, 8 weeks, depending on the feasibility and depending on your caseload. So that minimum of 3 to 5 visits should be there for the booking thing to happen. And as Rohan has said, yeah, definitely Anganwadi and the midwifery will definitely have a count in case the visit is done properly. Okay, so I see another question from Mir Nasir, whether hepatitis B vaccine is recommended to antenatal patients.
Sorry,
Rohan?
Priyanka,
Whether hepatitis B vaccine is recommended to antenatal patients.
Considering that it's if I'm not mistaken, it's not recommended during pregnancy. I think it's recommended post-pregnancy. I'm not very sure about that, Priyanka.
No, that is right. We do not give a hepatitis B vaccine during the pregnancy bit. It's the vaccination initially was TT, but then the triple vaccine of the DTP has come up. So that is what is recommended. Hepatitis B is ideally given post pregnancy and not during the antenatal visits, basically. Yeah. Okay. There's a question from Kumara Ranjita. Is there any increased chance of GDM and preeclampsia in IVF pregnancy? If yes, please explain.
So now, considering that IVF pregnancy is now depending on what exactly are the transfer protocols that are followed. Now, when we look at frozen embryo transfers, where most of us are doing frozen embryo transfers, now again, in that the protocols decide whether there's a higher risk of GDM or preeclampsia. It's then that when you do I think this is going to get a little detailed and complicated, but just think of it this way, that there have been studies which have said that in frozen embryo transfers where a hormonal protocol, where the estrogen and progesterone has been used to prime the endometrium for implantation, there have been cases of higher cases of placenta previa, higher cases of preeclampsia and IUGR. GDM has also been suspected in some of the cases, but a Nordic study has shown that it has less chance of GDM, but higher chances of preeclampsia rather than GDM.
Yes, okay. There's another question by Saraswati Munaswamy. And the question is, what about role of prednisolone in APLA and when to start?
I think prednisolone in APLA has firstly been controversial in beginning itself as it is. I personally don't use it in my treatment for APLA syndrome, so I won't recommend using it. Priyankur, what about you?
Yeah, prednisolone again in APLA, I also do not personally use it. There has been a couple of studies which have talked about a role of 2 milligram thrice daily dose of prednisolone in APLA at the point of diagnosis. But for me personally, I do not use prednisolone.
The study also was a very low power study with very few patients. It wasn't a robust meta-analysis or anything regarding that.
Correct. Exactly. Okay, so we'll take another last question by Neelu Singh. What is please highlight on the screening for thromboprophylaxis in pregnancy during ANC and postnatal care?
Highlight screening for
thromboprophylaxis.
Okay, so basically what you're again talking about is and everything where you would have to screen for recurrent pregnancy loss tests. So basically what majority of the things what you look at is the antiphospholipid antibodies, your IgG and IgM. Now, if you go to see your textbooks, the causes for recurrent pregnancy loss vary a lot. So basically, in that situation, you're looking at your growth, you're looking at anticardiolipin, you're looking at APLA, you're looking at beta-2 glycoprotein, you're looking at lupus anticoagulant and everything. But all the data shown that now when you look at your ANC care, it's said that you start with 0.4 mg of 40 mcg of your low molecular weight heparin, starting as early as soon as the heartbeat starts. After the heartbeat begins, you continue that throughout till delivery, maybe about 24 hours prior to delivery. After the baby is born, 6 hours after delivery, or 6 to 8 hours after your LSCS, you continue your thromboprophylaxis up to 6 weeks post gestation. Do not just stop it after delivery. That has to be continued for 6 weeks after gestation, after which we can consider stopping the thromboprophylaxis. So that is basically your thromboprophylaxis. The screening is basically you do your APLA test, your ANA, your ACA, your lupus anticoagulant. There are more further tests which you can consider doing, such as protein C, protein S activity, but all these tests can cost up to 34 to 40,000 rupees. So I think your APLA test is most common. And remember, 50% of your idiopathic RPLs are idiopathic. And there is no role of treatment besides tender loving care.
Yeah, so that is very true. I think that's all with the questions. Now I see one more last question, Rohan. Should we prescribe thromboprophylaxis in case of heart disease? In case of a heart disease like any left atrial hypertrophy or something like that? Should heparin be given maybe post delivery for any heart disease patients?
Post delivery, I think it's very important that you have to take this as a multidisciplinary approach in patients such as these. So if you have a patient with left atrium hypertrophy, I think it's important that you tie up either with the physician or ideally a cardiologist and have a discussion with them. See, at this point, I'm personally not going to be able to answer this question whether you have to prescribe thromboprophylaxis or no. I think in tie up with your team, with your medical team, like you have medicine residents, you have cardiology residents. I think it's important that you have you discuss the case as a team together and then decide whether that specific patient really requires thromboprophylaxis or not.
Yeah. So please remember, students, it's very important. The one-man show business, which used to be there 10, 15 years before, is completely gone now. It has to be a multidisciplinary approach. And if you, in case, if a patient, at some point of time, you land up in a trouble, the patient is, you might think that the patient is not that affording and it's okay, I will manage the whole thing for her. But then please do remember that if you get caught, if there is a problem that is happening, the patient is going to ask you, why didn't you take an opinion? And then you are going to be in a problem. So never take that chance.
Also remember, your job is to explain all the options available. Do not pre-decide in your head whether the patient has money or no. Explain to them that there would be extra costs incurred. If the patient is okay with it, you are not to make the decision about not providing that option. Your job is to give them everything that's available. Your NIPT, your quadruple markers, your anomaly scans, Doppler velocimetry, fetal 2D echo, everything should be provided to the patient. But at the same time, you tell them that, look, these extra tests are going to cost a lot of money. They are going to be expensive. If you are able to afford them, then go for it. If you're not, it's all right. We will figure out cheaper methods. That's why there was a recommended and there was a preferable.
Yes. So I think we come to the end of the session. Okay, there's Rishika Singh. The last thing, Rohan, I guess this is the last question that we're taking, guys. So when to stop aspirin in high-risk patients? And she also asks how to decide 75 or 150.
So when I look at pre-eclampsia patients, I always start a dose of 150. If the uterine artery Doppler and the PLGF, uterine artery Doppler shows high risk along with the PLGF being low, I always start a dose of 150 milligrams of Ecosprin. I start it as soon as I possibly get the what do you say? As soon as I get the report saying that she's a high risk for preeclampsia. They say ideally 12 weeks. I think most of us are doing an NT scan at 11 to 12 weeks itself. So within that week, you should know whether she's a high risk or no. Secondly, when do you stop aspirin in high? They said 5 to 7 days, but even up recently with the hematologists and all, they're saying even 2 days prior is fine to stop it. But I think most of your patients are going to come in either in labor for a normal delivery or emergency LSCF. So if you're looking at stopping, I think 39 weeks is where you would think of stopping ecosprin, considering 40 weeks is the EDD. But a simple thing, if you're unable to stop the ecosprin, if you're unable to stop your low molecular weight heparin within that given time, do your coagulation profile, do your blood time, bleeding time, clotting time, do your PT-INR, do your APTT. These are going to give you a coagulation profile, and that will take away your stress that, oh my God, my patient is on aspirin, my patient is on low molecular weight heparin, there's a higher risk of bleeding. If suppose the blood tests are not coming or not taking place, carry FFPs. You have FFPs available. You can consider giving 4 FFPs before taking the patient for a cesarean if your PT-INR is raised. If your PT-INR is not available, keep your FFPs ready during the surgery itself, which will help in this. Always such high-risk patients have to be delivered at a tertiary care center. Ensure you have all blood and blood products such as your, what do you say, whole blood, your packed cells, your FFPs, your cryoprecipitates, if possible, your factor 8, etc., all those things as well. So, yeah.
Yeah, so I think that we come to the end of the session, and it was a wonderful session on screening in pregnancy. I think you have covered the whole bit of it, and I think I am very sure the students would have recommended. There are a few questions asking where will you get the slide because you missed the presentations. All these presentations will be put up on the Foxy website, so you can look at it, and then the presentations you will find it there. So thank you, dear students, for attending this session, and I'd really like to thank Rohan for taking this time out of his busy schedule and attending today's session and giving such a beautiful talk. So thank you, Rohan.
Before I just go off, I just want to say thank you to Alpesh sir, Jaideep Tang sir, Ashwat sir, you, Charmila ma'am, Niharika, and Shashwat, who have been such an integral part of the PG teaching program, and I think the PGs have been learning a lot. So I hope that all of you have benefited from this. And remember that at any point where we've been in touch. So if you need to get in touch with us for any questions or anything, always feel free. We're always available to answer any questions. Thank you so much.
Yeah, sure. Thank you so much, Rohan. Yeah, thank you so much, Rohan. That was definitely a very generous offer for the students. And please, I request all of you to make use of it. I'm very sure you will benefit from all the questions that you guys definitely asked. So we will definitely come back again next month with again 2 fresh sessions. We'll be putting up the details of it. And next month we have another big event coming up for the postgraduates. We'll tell you shortly once we are decided with it and once we are done with our basic homeworks. So thank you so much, postgraduates, for joining with us, and keep joining, keep encouraging us to continue with these programs. And I'm very sure we will be able to, I hope that we have brought some benefit to you in your learning process. Thank you so much. And I would like to really thank again Alpesh sir, President Foxy, Jaideep sir, Secretary General Foxy, Dr. Ashwat Kumar, the National Coordinator, Charmila ma'am, who's the convener for the PG Forum, Rohan, Niharika, Shashwat, me, all of us from the PG Forum, and of course Satish from Alembic, who has also given us the technical support.
Thank you, Satish.
Thank you. Thanks a lot, sir.
Thank you so much, everyone. Thank you, students, for joining. Thank you. Till next time, bye-bye from us. Thank you.
Thank you.
Ashwat sir, you're there. You want to say something? Okay. I think Ashwat sir is operating. That's what he has said. Okay, then we are in the session.